Good afternoon. Yeah. Good evening, rather. To understand, all TLIFs are basically same minimal. When it comes to minimal access, it's just a variation of technique a bit. To start off with, it is to do in a basic grade one stable listhesis. It's always safe to mark your bony anatomy on the skin so that you know where you are inside. The incision should be between 22 to 26 millimeters at least. A sequential dilation to be used as a periosteum elevator to take the muscle of the bony anatomy there. At the start, this is a 13-year-old video. At the start, it is better to have an expandable retractor, which is more forgiving and allows more space for you to work. Always check where you have landed, especially L4, L5, and L5S1, because a little bit of angulation can take you to the wrong place. This is a quadrant retractor by Medtronic. Take off the soft tissue. Microscope or loop is better. This is the view you get. This is where the L5 pedicle and this is where the L4 pedicle entry point is. We used to initially just take pedicle screw holes by using local anatomy to put solid screws because they were much cheaper. I prefer a chisel. You can use a Kerrison or a nibbler to do your facetectomy. A chisel gives a very clean and precise field that you require. That's the view. That is the superior head end. That's the foot end. That's the medial part, and that's the lateral part. Those waxed holes are the ones where L4 and L5 pedicle holes have been made. The ligament is taken out, the dural sac exposed, a little bit of the lateral aspect of the lamina removed there to give you an exposure of the disc area. The leaders need to be controlled here. You get a very clear view. Most grade 1 to grade 2 discases have fall back and have a good disc height. A proper discectomy is essential. I've seen a lot of surgeons just put in a shaver inside, rotate and bang a cage in. That will definitely lead to failure or non-union. It is very important to spend time in taking out the ipsilateral and the contralateral side cartilaginous end plate, to use curved curettes to reach to the far area, to use forward-facing curettes to remove the disc from the posterior annulus. And then I don't do this anymore, but this is a good idea to put in a rasp to open up the bleeding end plates. A box cut is necessary so that an adequate size cage is inserted. It's a good idea to check that your cage is proper and is sitting in the correct place. A funnel to put in your bone graft inside, because that ensures that it enters the disc trace, rather than when you use a forceps where even a small bone falling into the canal will be difficult to retrieve. Bayonet instruments help you have a clear line of vision. I use PEEK cages. Bullet metal cages are also fine. Confirming that the cage is in its place and stable, you need to go to the next step, and that's a complete decompression of the dural sac here. There's the over-the-top decompression. The end point of the over-the-top decompression is when you see the lateral gutter on the opposite side. As you do more and more cases, you will be able to do this better. So it's better to start with mild cases than to start with high-end stenosis initially. Check that the foramen is adequately decompressed. Passing the screws, you have to go lateral to the lateral aspect of at 3 to 2 o'clock position. Put in a Jamshedi inside, go beyond into the vertebral body, pass a guide wire. This is the most dangerous step in an MIS TLIF. This guide wire, if it migrates forward, will cause a lot of problems. Once the guide wire and the protective sleeve is over then you can tap this much is enough. You can just go beyond the pedicle. This is initially we used to go right up to the tip. It is very important to maintain the guide wire in its place. Use the dismantleable screwdriver so that you can take advantage and hold the wire. Always hold the wire whenever a screw is being passed, because the screw can take the wire forward. At the part where the tip of the screw is beyond the pedicle, take the wire out, put in the screw. The next screw also goes in. Ensure that the heads of the screws are at the same level so that passage of the rod is simple. This is how a grade 1 or a grade 2 would look like. That's the end point of the surgery. These are representative images where you have restored the height Always compare the height to the next normal level so that you have an idea that the restoration is normal, as is the lordosis. In a flexible high-grade listhesis like this, just positioning on the right-hand side will reduce it by 1 grade. This is the video of what happens afterwards. The initial part remains the same. This is the overhang. That's the superior. That's the foot end. That's the medial aspect. That's the overhang of the S1 vertebra. But since it is already reduced, there's some space created here. I'm using a small 2-number kerrison to nibble at the overhang of the S1 here. Then putting in a 7 millimeter puka chisel. This is a sharp puka, gently opening up the disc space there. There is no point in being very, very firm or use a lot of force, because it will end up biting into the soft bone there. After this, I prefer in such listhesis to put in a blunt puka chisel, so that it distracts the disc space and achieves the height that is necessary. And of course, then the curating goes as it would be seen previously. This is in the flexible high-grade listhesis, which form a majority. Unfortunate, and this is what this is a good restoration in this case. This was actually a redo. This was the scar of the previous surgery. This is the T-leaf scar, and I prefer to put my screws very, very wide so that you get in long screws. So that's the reduction that you're seeing. Sometimes, about maybe 1 in every 6 high grade, you'll get a very stiff construct like this, where even putting a number 4 Penfield is difficult. So in such cases, I have this armamentum with me. These are 3-0 lumbar curates, bayonets at various angles. You have to have a whole range of this. This is my personal instruments. I've got them custom made. This is very important to have your own set, because you're familiar with it and you know what you cannot do. I'll orient here. This is the foot end. That's the head end. That's the medial end. That's the lateral aspect. This is a stiff listhesis. I'm taking out the superior tip of the S1 facet there. This 15-number blade barely going inside. There's hardly any place to work. So we start with a small, that Penfield also is not going in. Start with a small 3-0 lumbar curate to make space slowly. This is a very surgery that requires patience and time. There are no quick exits here. Once you have made a very small area, then you use a 1 and 2 millimeter lumbar kerrison punch to just take out the overhang, because initially you won't get place for that too. Once that overhang is connected, again, this Penfield, it's not good enough for the Penfield to go. You got to work some more. Here, what I'm using is a chisel. I'm just making a small entry point with this chisel. And once it is sufficiently about 1.5 centimeters inside, toggling it a little bit and not rotating. After that, this is a 6 millimeter height and 3 millimeter width puka that I'm putting in blunt to gradually open up this space. This is not tight, not opening up so easily. So then I will continue, try again to loosen it up with curates. Try to slowly eat up the overhang with a kerrison rounger again. The trick here is to restore the vertebral height and release the disc. If you don't do that, you're never going to be able to get a reduction, and that anterior part never will be weight bearing. Now I'm able to open up the smallest, that's the smallest puka chisel. We leave it there for a minute or two so that the soft tissues get stretched. Then again, using a bayonet 3-0, I go to the opposite side, slowly take it out from the opposite side to expand, then use angle curates to reach to the opposite side. And that makes enough space. And then gradually distract this. I'm going to go a little bit faster. I'm running out of time here. And then putting this puka and increasing gradually to get reduce this to something like this. This is a patient at 1 month post-op, able to squat. Some of the tips here is when you're positioning L5S1, it's at an angle. It's better to give an head high, so that giving a head high makes it more vertical and it's ergonomically better for you. These are the paddle shifters I'm talking about, blunt pukas from 6 millimeters to 16 to gradually open up. That's a radiological image of them at use. It is very important to get a bicortical hold via navigation. I'm not going to show this, or even when you don't have navigation, it is important to get a bicortical hold. Otherwise, your implants are going to fail. A rod can be used if you have a good reduction, rather good release to reduce your listhesis here. Cage can be used, but I don't prefer it anymore because a cage is not substitute for good intradiscal work. It is useful in obese patients. It's 5 years old in multi-levels like this. We have 2 presentations, one a case report and one a poster for 12 cases we have done so far. This was in 2018 global spine poster presentation. So far now we've reached 24 high grade lists. These are the parameters of correction that we had achieved. Thank you.
Thank you very much, Vishal, for an excellent presentation. By the time there are questions for you, I'll request our Yuvraj Singh, Rupinder Singh, to load his last presentation. He is a man who can hit 6 sixes in 1 over. So Rupinder is ready. Any questions for Vishal Peshetiwar?
Vishal, question from Dr. Doke from Aurangabad. Sorry, from Nagpur. He says, he asks you that, sir, excellent presentation, but you showed a couple of cases of grade 2 listhesis where you have reduced them and with a minimally invasive technique. Does a low-grade listhesis require a reduction? Or in most low-grade listhesis, the goal is decompression and fusion. Why bother with reduction?
So it's not just a question of decompression. When you reduce the listhesis, you also restore the lumbar lordosis. So if it is possible, you should always attempt at correction of the deformity. So the adjacent level load is theoretically lesser and you will have lesser chances of ASD if you have restored the lordosis back. So that's my reasoning behind it. I mean, there are people who do not reduce it and that's their choice.
If you want to use, I have a question. If you have to use like L4 and L5 to pull it back with a reduction kind of a system, how do you do that with this system?
Kshitij, I don't use L4 screw at all in any of my cases. Now we have 24 single institution, single surgery cases at the Ambani Hospital. Before that, we had done another dozen odd with me and my partner Devesh Dholakia. And so far, all these cases we have followed to their fusion, which is documented by a CT scan. None of the screws are pulled out. The trick here is to use the paddle shifters, distract, put in reduce it and put in a cage so that the load bearing is at the cage level and the screws just work in neutralizing the torque. Most of these patients have been osteoporotic. We have supplemented some with teriparatide and it has worked in most of the patients. We have never required to go to 4 to get an additional purchase, nor have we gone into the S2 ileum to get an additional purchase.
That's all right for grade 1, grade 2, but when it becomes higher grade, then that becomes tough.
See, majority of this are degenerative cases which have reduced. I've shown my X-rays there.
It is lesser.
Even the ones that were not reducing. See, Dr. Rajkumar Deshpande has a very beautiful paper on this. He has presented 27 cases where he uses the, the arc mechanism of a sextant device to reduce. I personally feel if you're reducing on a screw, there is too much pressure on the screw and that's there are high chances that this will fail. That's why you need additional purchases. If you have reduced and put in an adequate, you have done an adequate reconstruction of the disc space, then the screw pressure is much less and this have a lesser tendency to fail. So I follow that. Even in our rigid ones, now we've done about 6 to 7 of very, very rigid ones where we have spent about 1.5 hours to get that disc space back into its place. And it has been worth its while because all of them have gone and progressed to fusion with just that level being fused.